Okay, so I'm just hitting record. And Kat, if I can just get your permission while we're recording to record this video and then to share it with Lifebox and with other members who might be interested to hear your perspective.
Yes, you have my permission, Tom.
Perfect, thanks. Why don't we go off video to preserve bandwidth?
Okay.
And then why don't we start by why don't you tell us who you are, what you do and where you work, and a little bit about how we got to know each other.
Sure. So my name is Katherine Chu. I am from the United States originally when I trained there as a general and a colorectal surgeon. And I've been working in sub-Saharan Africa now for about 12 years, mostly in South Africa. Currently, I'm the director of the Center for Global Surgery at Stellenbosch University, which is located in Cape Town. I also am the vice president of Doctors Without Borders here in Southern Africa, which is a humanitarian medical organization. I know Lifebox originally from my time in Rwanda in 2012, where the NGO was getting started with their pulse oximetry distribution. And I know Tom from our shared work around global surgery and research here in sub-Saharan Africa.
Fantastic, thank you. So Kat, tell us a little bit about what the current situation is in South Africa. Obviously, you said you're in South Africa. I know that we talked earlier that much of your work right now is administrative, but tell me a little bit about what's happening in the country, what's happening in terms of testing, in terms of cases, and in terms of kind of general preparation as you see it.
Sure. So we currently have almost 1,400 cases, and we got our first case just a little over 3 weeks ago. Starting 7 days ago, a week ago, the president announced a national lockdown, which I think is similar to parts of the US, Italy, and China, where people are asked to shelter in place at their homes and only allowed to leave their home to buy food or to seek healthcare. We have currently tested 44,000 people. So I would say that our testing has been way behind other countries. At the moment, we only have the PCR test available, and so far it hasn't been widely available in the public sector. And just to give you a background, 85% of the population seeks care in the public sector. That PCR test has also taken up to a week or even longer to come back. And so even though there are many patients who meet the criteria for persons under investigation, which would be to be symptomatic with the fever, the cough, shortness of breath, as well as having close contact with a case or having traveled overseas. If the person is ambulatory, they are asked to stay home and self-isolate, as opposed to not necessarily always coming in to be treated. Some people are coming in to be tested. Some people are being tested in that category if they are not able to self-isolate and if they have other comorbidities, or they would be at high risk to expose other people. Anybody that needs hospitalization that meets that criteria are being tested. And so the majority of those 44,000 people are ones that have come in to be tested in the hospital. Secondly, the majority of those being tested, so 3/4 of those were all done in the private sector. Wow. In South Africa, which is a very unequal society economically, this disease started with the wealthy, the upper middle class, because initially our first cases were all those who had travel histories, which is no different than other countries. And only now are we seeing the local community transmission.
Wow, so it's amazing how similar that is, certainly to the experiences of what we consider very, very high income countries, the US, the UK. Certainly in the UK, we're experiencing the same thing, and the recommendation up until only really just recently was exactly the same. Patients who didn't need to be tested were basically at home not being tested, and we don't really have good visibility on how many patients have got the disease and recovered, what the real community prevalence is. So very, very similar situations.
Yeah, and I think that we are taking our guidance from the countries that are ahead of us on the curve, and most of those are high-income countries. And I think the real concern is, even though we can see that social distancing and lockdown is working in high-income countries, how are we going to be able to carry that out here in South Africa, and B, how does that affect us economically? Because already 30% of South Africa, for example, were unemployed. Prior to this, in the last quarter of 2019. And a big part of our population relies on social grants. But there are quite a lot of people who don't have a lot of savings. And so if they lose their jobs as kind of casual workers, or if they work in restaurants, there really isn't a backup system for them economically. So the real question is, are we even going to be able to do social isolation in this country on a national level?
Yeah. So, do you mind if let me ask you a little bit about that? So, what does social distancing look like in in very densely populated urban areas, in Cape Town and Johannesburg? I mean, how does that even happen?
Yeah. So I mean, at the moment, again, most of the cases have been people located in wealthier areas, but we're now starting to see cases in the townships. And in the townships, people live in one-room shacks with multiple people sharing that one room. So the government has recommended, WHO has recommended 2-meter distancing between people, and that certainly can't happen in these households. Access to clean water and soap to wash your hands if you do need to go out, also not really available. And if somebody gets sick and needs to self-isolate, because we haven't built extra field hospitals and we don't have the space in hospitals for people to be isolated, if we do have a lot more cases, how would that work in a house? Because if you are a case and you're supposed to self-isolate at home, you're supposed to have your own bedroom and your own bathroom. And again, that doesn't really work in the townships. Yeah. And the other thing is that so far, we're a week into our lockdown. A lot of the townships, it could be due to lack of social media or lack of awareness, but it has been quite difficult to get the population to stay inside, because staying inside means staying inside a one-room shack, and that's very difficult. Our government has said that you can't go outside to exercise either. I think in some countries you're sort of allowed to go out and about for an hour a day as long as you stay 2 meters away from other people, and that hasn't happened.
Right. Wow. So tell me a little bit about the preparations that are happening in the hospital. And I know, like I said, I know that you have a lot of administrative responsibilities, but what's happening, at the hospitals where you work at, in terms of preparation, particularly from the surgeons, the anesthesiologists, the surgical capacity side, because obviously this is not a surgical illness, but it clearly is going to take up a lot of the resources that are typically used by surgeons and anesthesiologists, and also even the mechanism, supply chains, kind of logistics that are very common to surgery are going to be essential to even remotely keep hospitals running. So tell me a little about the preparations that are happening.
Yeah, so in South Africa, we have about 6 or 7 large tertiary hospitals in the public sector who have more than like 2,000 beds. And almost all the ICU, high care ventilators are used either somehow related to the surgical system. In South Africa, we have a high rate of, or high need of emergency surgical cases. Particularly, we have a high trauma burden. And so the first thing that we did in South Africa was to limit elective cases. So in South Africa already, it's hard to know because we don't have great statistics, but we do more emergency cases than we do elective anyway. And so by limiting elective surgery, it actually didn't decrease initially the burden of surgical cases in the operating room as much as we had hoped. But pretty much now every hospital across the platform have stopped elective surgery. I think like most countries, the cancer cases is a little bit of a gray area. And that being said, most of our hospitals, for example, Tygerberg Hospital, we have 3,500 beds, but we only have, I would say, I think less than 35 ICU beds total between the medical and the surgical ICUs. We have now expanded that by taking some of the ventilators from the theater to try to make capacity for 44 ventilated beds. And still, for a hospital of almost 4,000 beds, that is not very many. And we serve an area of about 2 million people. The hospitals themselves are being reorganized. So a lot of the wards are being closed down. The surgical wards are being turned into wards for COVID-19 cases. The ventilators from theater are now being repurposed to be used in preparation for COVID-19 cases. Also just to say about the anesthesiologists. So the anesthesiologist, as I think in most countries, people realize that they are probably at the highest risk just of intubating and extubating patients. And in order to reduce the exposure to all the healthcare workers, well, first of all the students are no longer working in the hospitals, but to the interns, the trainees, the residents, only attending or consultant anesthesiologists are now intubating patients, and that goes with the same in the emergency room. So that, again, is to limit the exposure for healthcare workers.
Yeah, yeah. So tell me, I mean, repurposing the anesthesia machines as ventilators. What would you anticipate the implications of that are? I mean, you already said that there's a high, emergency surgery requirement. What are the implications of doing some of this repurposing that you're seeing?
Well, I think, it's just a matter of trying to figure out how many you still need to keep open and available for emergency cases. The obstetrics, the cesarean sections are always going to be going on in the trauma cases. And so we have emergency theaters that have always sort of been designated emergency theaters, and we have all the other theaters that, those kind of cases are really trying to essentially close down or really, really slow down. But again, as you say, it's hard to know because at the moment, we aren't at ICU maximum capacity with COVID-19 cases yet here because we're behind on the curve. So we don't know. But I think that the real concern of all our public health specialists, our surgeons and our anesthesiologists, is that we will hit maximum capacity pretty quickly. We don't have kind of ways to acquire more space, for example. There are discussions now by our province and national to order more ventilators, but I think the concern is, do we have qualified staff to monitor those patients?
Yeah, so that's an interesting point. There's we were talking before the recording started about some of the capacity needs, particularly around some durable goods, so say ventilators or the consumables like PPE. Where do you see these major bottlenecks? I mean, obviously, you can order and obtain a bunch of ventilators, but if you don't have the human resources to staff them, that's an issue. You can put a lot of workers on the front line, but if you don't have PPE to either protect and certainly to reassure them, that's going to be it's not going to be a particularly encouraging strategy. So where do you see the major bottlenecks in South Africa?
Yeah, I mean, I think that we had been having issues with PPE. We had about 1,700 bottles of hand scrub stolen from Tygerberg Hospital a couple weeks ago, so that wasn't great. But there have been organizations that have stepped up to pay for and help supply more masks, more gowns. And so at the moment, that isn't our problem. In terms of the human resources, I think that's a real problem. I mean, in the public sector, we've always been short of nurses, desperately short of nurses. And now, even more so now, it's going to be more important, or that's going to come into play. In terms of staff, for many surgical services and intensivists, they're really trying to do kind of, I guess, save some of their healthcare workers. And so they're putting people on for 2 weeks at a time and then pulling them off for 2 weeks at a time, so that, the healthcare workers are not working all at the same time, with the thought that people will get sick and we don't want to get too many people sick at once. And so kind of putting people on rotations, to have the fewest people exposed. So most services are down to skeleton staff. And also, just to bring up, in South Africa, we have a very high HIV infection rate. And for example, the pediatrics department was very concerned because the Tygerberg, one of the big tertiary care hospitals, has lots of chronically ill kids coming into the outpatient clinics for their medications. and needing checkups. Kids on dialysis, kids that are chronically immunosuppressed, and really they couldn't figure out what should we do with all those children. And so for that, for example, they've tried to send everybody home with 6 months of drugs, of medication, and telling them not to come back unless absolutely necessary.
It's a massive effort. It's a very different way of organizing, not just the way the providers are allocated, but also just the entire service line, to try and to go from taking care of kids who are really have chronic needs, that you normally see them fairly regularly, to suddenly kind of creating a new social distance. That's going to be it's a monumental challenge, and obviously comes with a lot of potential risks for those vulnerable populations too.
Yeah, and also I think that, some of the things that have been working well, I think, for example, the UK is doing a lot of like telemedicine kind of doctors' visits online, and those kind of things we don't know, but we don't think are going to work so well here in our population, because most people that come to the public facilities don't have access to bandwidth, internet, computers, iPads to be able to do those kind of online visits. And even cell phone. I mean, even being able to get the money to afford cell phone credit to phone in is going to become a challenge when people are really living hand to mouth every month and don't have savings to dip into. So I think we're quite worried about kind of what's going to happen to all the non-COVID people as well, patients.
When you were describing the whole way that you're organizing the providers, it's almost what you're describing as flattening the provider infection curve as well. Not just with social distancing, hopefully flattens the population infection curve, but spacing out providers in that way is hopefully also flattening the provider transmission curve.
No, exactly, and that's quite grim, isn't it?
It's so. So obviously it's it's certainly a scary time, as you described. It's a very scary time to be an anesthesiologist, to be a frontline provider, to be really anybody who's going to be working with very sick, very ill patients. What are your main fears with all this?
I think our main fears really is that we're not going to be able to cope with the number of infections that we're going to get. We're not going to have enough healthcare providers to provide for all of them. I think specifically for the doctors and the nurses, I think also just the fear of going to work and transmitting it to their families. Nurses at the moment, because there's a lockdown, many nurses don't have their own cars, and so they're relying on public transportation to get to work. And most of that has also been closed down. And so they're having to stand in long queues for the few taxis that do, minibus taxis that there are. And nobody wants to bring it home to their families. I think everyone here, just like healthcare workers around the world, are committed to treating the sick patients in their hospitals, in their countries, but bringing it home to your families is always a risk that people don't want to take.
And tell me about what gives you the most hope about what's happening. If anything, tell me what you're hopeful about.
Yeah, so a couple things. First, that because South Africa, which has the most infections of any African country so far, because we are behind some of the other countries such as China, Iran, the US, European countries, we have been able to learn that social distancing has worked for other countries. And so I do think our president, Cyril Ramaphosa, took an early stance on social distancing. I think a lot of the population felt like in some countries that it is too much, it's overkill. But I think that most of us believe that this is something necessary. In fact, in hindsight, probably should have done it a week or two even before. So hopefully we won't get as many cases. The second thing, and these are unknowns, is that we have a much younger population than most of the other countries. And so, it seems like the biggest risk factor is age. And we have a very young population. In all of sub-Saharan Africa, only 6% of people are over 60. I think in South Africa, it's a bit higher than that. And so perhaps we may or may not be hit as hard. So we are hopeful on that. And then the third thing is that, even though we have a very high portion of our population that's HIV infected, 90% of them are virally suppressed on ARVs. And as long as they can continue to get their medications, hopefully, even though they have HIV co-infection, perhaps they won't be at more risk than others. Yeah. And I think the last thing that gives us hope is that, during the HIV era, I guess 20 years ago now, civil society really did a lot to move HIV forward in terms of political action to get treatment and coming up with kind of community-based solutions. And I think we're seeing that now as well, even though it was a very top-down approach for the social distancing by the national government. Communities are now sort of coming together to try and figure out for themselves, especially in the townships, what will actually work for them. And I even seen some wealthier, so affluent communities, their community groups partnering with the township community groups to be able to provide, for example, drums of water with soap in it, that has a foot dispenser for people to wash their hands, provide food packages. So even though they themselves can't come out, they're providing the funding and the logistics behind that kind of stuff. And I think for Africa, that's going to be really important because, community, I think in this part of the world is more important, or as important, but probably more so, to hold the society together than in high income countries. And so I think that hopefully communities will activate to try and work together.
Yeah, right before we started recording, we were talking a little bit about some of the fears, kind of geopolitically, of kind of the kind of retrenchment to nationalism, and a little bit more of inward-looking assessments, particularly for countries that have traditionally been the big donors. Obviously, are getting very, very hit with COVID-19. But when you have these kind of situations, it actually seems that rather than ending up in some kind of apocalyptic horror, communities seem to rally all the more strongly to come together, because they recognize that as a society, as a group of individuals who all have to live together and work together, that's how we beat this. And I guess it's been very encouraging to see those kind of new and strengthened community relationships that you're describing. I do believe that is a huge opportunity that needs to be leveraged, and not obviously not just now, but hopefully for a much longer term.
Yeah, and hopefully, I mean, it also gets countries and governments and NGOs and civil societies to work together across national borders as well. I mean, in South Africa, we have a very high migrant population that's often put on the fringes of healthcare, and groups like MSF and many other kind of NGOs are really now looking to see how can their health rights be protected, or how can they access care. Certainly the very large homeless population in the big cities, they are at high risk for COVID-19, and they put other people at risk for COVID-19. And we were discussing how in the UK, a lot of the hotels are opening their doors to these what they call rough sleepers. And here in South Africa, we have schools that are empty. We have hotels that have no clients, and so can be kind of utilize that part of society, which often hasn't really shared its resources with the poor, to be honest, in South Africa. So we'll see.
Yeah. Well, Kat, listen, it's always a pleasure to connect and to talk. Thank you so much for taking the time to talk. I really appreciate it. I wish you the best of luck, and that you stay healthy and your family stays healthy. And let's keep in touch over the course of the weeks and months, and let us know how we can help support, and please keep this kind of perspective coming.
Thank you very much for your time, Tom. And I really wish Lifebox the very best of luck in these times. I think a pandemic like this really, showcases the importance of being able to bring supplies into sub-Saharan Africa. And we thank you for Lifebox work.
Well, Kat, we really, really appreciate it. And thanks so much.